Welcome to our webinar hosted by the Saudi Heart Association and the Saudi Society of Echocardiography. It's our pleasure to welcome all our speakers and panelists attending with us today. We have two speakers, two very well-known speakers, Dr. Mary and Dr. Gary Sato from UCLA. We have two eminent local panelists, Dr. Khalid Attas from Mecca and Dr. Khalid Zahri from Eastern Province, and this is Miri Mabader from Jeddah. So the webinar is going to take about 1 hour, and then we are going to have the questions and answers at the end. If you're joining the Zoom, you will find at the bottom Q&A, and you can send it, and I will forward it to you. And this webinar, you will get 2 CME hours accredited by the Saudi health authorities. We would love to start now. We have around 1,000 participants in our family, and can I introduce, every one of our speakers wants to introduce himself, and Gary, would you like to go first,
Sure.
Please?
I'm going to share my screen.
Could you kindly introduce yourself, please?
Yes, thank you, Rima. Can you hear me fine?
Yes.
So my name is Gary Siu. I'm Director of Pediatric Echo, Co-Director of Fetal Echo at UCLA, both UCLA Mattel Children's Hospital. We're a hospital in a hospital. Ronald Reagan UCLA is the greater hospital. And I'm going to spend the next 15 minutes or so speaking on considerations for the Pediatric Echo Lab during these trying COVID-19 times. I want to thank you, Rima, and the Saudi Heart Association for inviting me to speak. So I think something we were all talking about just recently before we go live here was that COVID-19 really is still in process. Reasons that the webinar like this one today are so helpful is we can compare and contrast notes and experiences from around the world in real time, and for sure this is affecting the world in many different ways. And so although we're going to talk about the Echo Lab, I think the first thing to say is what we have with regards to preliminary data, experiences, anecdote are really just that. They're really varied and mixed and vary so that even if there's a global impact on this terrible pandemic, there's really quite a variation in terms of regional involvement, presentation, all those things, socioeconomics, things that we're not going to be able to touch on today. And most of these are things you already know. But I think even mentioning these certainly are worthy and play a part in how our own hospitals and our own Echo labs choose to conduct things right now. There's definitely institutional variation as well. So I think each institution and hospital and Children's Hospital chooses to strategize and approach and minimize problems as best as we think we can. And that may morph or change to some degree depending on where in your town and city and region you think you are on the curve. And then that's not to mention that for better or for worse, although we have a lot of the KD-like anecdotal reports recently, the general census is it seems to be hitting the adults much more than it does hit our pediatric patients, for those of us that are pediatric cardiologists. Nonetheless, we're all involved in one way or another. So I'm not really going to talk about clinical COVID, but just a slide to show just within the last 24 to 48 hours, random pictures that are in, various media formats. This picture on the left is a nice illustration kind of demonstrating how we think the SARS-CoV-2 organism kind of works its way into the body, into the myocardium, how the end product might be anything from arrhythmias to myocardial dysfunction. I would have less experience with acute coronary syndromes in that setting, but certainly there's been occasional cases reported. And so all of this at the science level is of recent starting to show reports of a Kawasaki's like auto-inflammatory picture that everybody is starting to compare notes about now. For myself, obviously there's a lot of different resources one can utilize to get a sense on the numbers. Every morning when I wake up, just for example, and I look at the local paper, they have a daily count. You can see this is for more or less kind of a curve showing where we are. UCLA here in Los Angeles, there's been about 3,200 cases and about 1,500 deaths. Up here is the state of California, and just under 3,000 deaths so far. Now, this pales in comparison to New York City, but as Mary was mentioning, other cities may be at different time points, and we'll have to see what the final numbers are. We're all working our hardest to try to minimize these. UCLA Health has done an outstanding job, in my opinion, in terms of communicating, enforcing, and updating us on all kinds of things. And with permission from Dr. Bob Cherry, who's in charge of UCLA Health in terms of this COVID era, this is an example of an email update that the UCLA employees all get. And it has a number of different items on it. Here are a few of them. But if you look at an update, it says here that at UCLA, since March 9th, we've tested over 13,000 patients. There were 840 that tested positive and just under 200 admissions. There have been 135 discharges and 17 COVID-related deaths to date. At the moment, they give us updates, and that includes 41 hospitalized patients, 18 in the ICUs, 13 on vents, and so forth and so on. Now, before I go further, this is all of UCLA Health, and this is almost exclusively adults. So this is not our pediatric population. And then the list goes on. But this is a nice example of what our institution's done for us every day. And then on our homepage, within our computers at work or remotely from home, we have all kinds of resources and updated information on a live ongoing basis, all kinds of generalized guidance for staff at different levels and things to be thinking about. And so I think that from an institutional standpoint, even before you walk up into the Echo Lab, those are the kind of things for us as employees are helpful to have a sense of where things are at on the curve and what we're looking at in terms of the individual numbers. This is a photograph I took last night on my way out to the garage. Every single entrance to every part of UCLA Medical Center and outpatient buildings on campus have employees that are basically taking a temperature with the thermal scan. We have to report the presence or absence of any of these symptoms as you see listed. And there's a reminder in clear kind of illustration reviewing the various things that we need to think about for care of ourselves, for protection of others, and for social distancing. Now, ironically, we're talking about a lot of death and destruction from this terrible pandemic, but if you look at a recent pre-press publication, when I chose to review PubMed, some of the stuff in the last week or two, here's in JACC, a work titled Safe Reintroduction of Cardiovascular Services During the COVID-19 Pandemic, Guidance from North American Society Leadership. So just to show how in flux we all are, you can see that not only are we all on our own individual curve, but already ACC and in JACC is starting to put out some very early feelers on how to think about reintroduction, because certainly this is not a quick landing, right? This is an elongated course of unclear but probably prolonged time, and it's hard to know exactly how to do any part of this best. So it's a moving target. Specifically related to pediatric echocardiography and echocardiography right now, the majority of my information is going to be based on what most of us are using now out here, which is the American Society of Echocardiography's statement paper, and that is ASC's Statement on Protection of Patients and Echo Service during the COVID-19 2019 outbreak. And this was a general work in the beginning of April. There are a couple of additional pieces for those of us in pediatric and fetal congenital heart care. There are subsections with mostly parallel but some uniqueness. As you all know, our patients are unique in a number of ways in regards to the pediatric and fetal care of imaging and the pregnant patient, some TEE information, some for the sonographers in general. And while we do this less, it has become more interesting to some because of the miniaturization of the technology and the hypothetical argument of reduced transmission of infection. This is specifically the pediatric paper, and of note, Mary is one of the authors on this paper. And all this says is specific considerations for pediatric fetal and congenital heart disease and echocardiography service providers during the pandemic. So this is the sub portion, if you will, of the main paper. And I'm not going to read these other than to say this is a short list, and there are more out there if you look, but this is a short list of the resources that they utilized for the paper. And if you look, it includes AIUM and SMFM and some of the other ISWAG, some of the stuff that we fetal folks tend to utilize a little bit more often. But what are the key points here to think about with regards to pediatric echo labs right now during this period? Well, if you break it down, the paper and all of us really need to say, whom should we be imaging right now? Are we imaging no one? That's not possible. Are we imaging everyone as normal? That's not possible and shouldn't be conducted. So of the variables we're looking at, I think each institution is thinking about how they can follow the guidelines, which really recommend trying to reduce the use of echocardiography compared to what we all know and love on a daily basis. And not only who should you limit echo to, but also where are you going to do it? Are you bringing people into a crowded echo lab? Are you doing it portable? Are patients isolated from other patients? And so forth and so on. How to image. Should everybody have a full study? Should everybody have a limited study instead to minimize exposure time? These questions may or may not have the obvious answers. There are guidelines suggested in the paper, and I think we each make our own decision based on the indication for the echocardiogram. The level of protection is somewhat variable, but generally, non-respiratory exposure or droplet exposure versus respiratory are the two general categories regarding when you're simply going to be using a standard surgical mask and gloves versus an N95, a shield, a gown, gloves, and so forth and so on. Personnel is something that was also highlighted. Is it appropriate any longer to have a first-year fellow go do a complex heterotaxy that has a SATS 68 in the NICU? Well, maybe it should be someone that can go in and get out quicker and minimize exposure in that sense. So there's even up for grabs an argument who should be doing the studies in addition to where and when and what patients. This is a picture taken from some of the publications, just demonstrating some of the more common machinery protection. And this is kind of something that can go over the whole screen, something that can go over a transthoracic transducer, some other items, including for the TEE. And we're not doing this, and this patient, rather sonographer, obviously is more modeling. She doesn't have any face protection at all, but this is an example of what one could utilize over the patient themselves to minimize exposure. This is the more typical surgical mask. Believe it or not, times have been hard enough that the cafeteria at UCLA is selling toilet paper and paper towels. So this was a photo someone took of me getting a couple paper towels in the cafeteria. This is a photo from the operating room. You can't necessarily tell well, but I'm wearing a mask. We kind of jerry-rigged it a little bit. I have glasses. This is an N95. The gown's already off, but we're gowned, we're gloved, and we're wearing something of a different nature when we're performing transesophageal echocardiography. Here's an example of a shield that's kind of full length, and an example of our institution telling you a little bit about the shield and some of the appropriate or inappropriate ways to clean that shield for repetitive use. Here's an algorithm that came from the overall COVID statement looking at how we should approach things. So, suggested algorithm for determining indication and level of protection. Is an echo really needed at this time? Well, if you say to yourself no, many people will say forget about it, let's move on and wait. On the other hand, as you know, there's plenty of patients, no is not an answer. You need to find something out to help care for them. In that case, you break it down into either COVID, suspected or confirmed or not. If there's a low suspicion or negative testing, we're generally using the standard precautions, but people may choose to use elevated precautions. For transthoracic echo and for stress testing, that may or may not include this kind of pathway. Okay, but airborne protection in intensive care unit, in our operating rooms, in the cath labs are going to include the higher level of PPE. And obviously TE, anywhere you do it, really falls in that same category. If someone has high suspicion or confirmed testing, then in that case, you still basically end up with the higher level PPE, but you may also, depending on your philosophy and what you need to the approach of the patient or the child, you might consider going with the more limited but miniaturized technology if you have it. To get in, get out, do a quick function check, fluid check, for example. Unfortunately, we often still need to do studies that are beyond those simple ideas. And then again, limiting staff. This is not the time to bring the fellows and residents and everybody else watching, and really minimizing all kinds of things, both exposure time. The paper suggests that anyone over 60 should also probably not be participating. Fortunately, I'm not quite there yet, but I think that there's a lot of indications that if options are available, include those with vulnerability due to chronic illness, immunocompromisation, and the pregnancy state. From the general COVID paper, here's the summary recommendations for the policies and the procedures during the outbreak. So again, offer possibly deferring or rescheduling patients, assessing for their status. Everyone at our institution gets screened, as I showed, and that includes every patient and child's wearing a mask when they make it through clearance. The TEs, because of the high risk, we're only really doing them in the operating room. The cath lab is needed. We're not really doing outpatient TEs right yet. And then the PPE approach is a little bit variable by institution, but the higher road should be taken when in doubt, and certainly when exposed through procedures like we pediatric cardiologists do typically, which is TEE, or for those of us that do it. Limiting exposure time, some of these things are really common sense. Even reading room behavior, we don't have a functional reading room anymore much because of the ability to have a reading, archiving, and reporting station on our own desktops. We basically don't need to physically go to the lab for some of the reasons we normally do. So we're all kind of in our own little areas as it relates to kind of the literal sense of an echo lab and where people congregate these days. This is an example of type of PE that are suggested during either airborne or the more routine droplet precautions. But you notice there's dominantly an overlap here. And again, I think on individual philosophy, institutional philosophy, no one's going to argue with washing the hands and gloves and even a gown. I-95s at a large place like UCLA Health can tap resources pretty quickly. So the institution feels that they stratify appropriately when you should use them or not use them, and how we can rehabilitate them and use them up to 5 times when properly utilized. But some of this comes down to pragmatism, not just pure individual preference. Here's from another, actually from a Heart Society in Poland, of all places. It's very similar, but I thought it was kind of a nice brief illustration showing the same ideas, that for echocardiography, for them at this point, everybody's kind of masked and gloved, and then you go through the step, and whether you're doing a surface echo or a TEE, I'm going to talk about TEE for a couple minutes before I finish. So if you go down the surface echo, this kind of goes through the same basic ideas of what to think about and where to go with that thought. If you have a suspected or confirmed patient, which is this red box, then they kind of break it down into other levels of PEPE that they feel is appropriate for the type of patient and that given high suspicion or positive patient. Very similar to what you've seen here in North America and elsewhere in terms of the few publications out there. This is a very detailed slide. This comes from the pediatric group of the American Society of Echo, specifically an example protocol. So bear with me as I read this. I'm going to read most of it, but it's very detailed. And this is one example of how you might go about a higher risk procedure, the TEE. So the suggestions start with what we're doing here at UCLA, as I'm sure most places, which is now testing is available and making sure one's negative within 48 hours of procedure, or in our case, congenital heart surgery as well. And then as you kind of move on here, the same thing has to do with optimizing the environment in the room, minimizing personnel, optimizing PPE, air purifying respirators and other things. That's really, again, institutional. If you have that at your availability, if you're at the higher PPE level kind of paradigm. Some have suggested that anesthesia place the probe, which is interesting because someone's got to do it, so they should be properly prepared too. I think the important thing is that all of us in that area, in that little confined areas, as you know, should be properly suited up. And then for the patient that's positive or symptomatic that you're actually unlucky enough to have to consider transesophageal echo, you know, the same kind of thing, but more including strict isolation and, you know, very formal donning and duffing in the room, out of the room. And honestly, you don't need to memorize this. There are nurses at the unit, at the bedside, in the procedure rooms who know what they're doing. They're not going to let us do anything less than what's required by infection control in our institution. And so just like when patients have infection control parameters pre-COVID, the same goes for COVID. Here's another one that I think for the sake of time, I'll skip, but basically looks at how to approach TEE, again, before, during, and after the procedure. Here's an example of someone performing the procedure. Notice the cord and the probe is draped, the machine is draped. They basically put the mouthpiece through and then they put a hole through the end. And so ultimately what you have is the probe that protrudes out from the protection and is obviously in the patient, utilized in that format. Point of care ultrasound is something we don't necessarily do a lot of in pediatric cardiology because as echocardiographers, we know the extensive limitations. But the ACE large group did come out with a couple of ideas regarding if you can downsize to a limited machine or have that ability, what kinds of things in terms of structures you might be able to get in the setting of COVID and what you're looking for. I'm going to spare you from me reading them. So in summary, without question, in terms of considerations for the Peds Echo Lab right now, everything is still evolving, very dependent on who you are, where you are, county, city, state, national, international. I think common sense is the theme of all of this. Whom should go, whom should scan, where do you do it, how do you do it, and what do you really need? You should ask yourself that every single time. The PPE technology, I think at this point, most people have it at their institutions. It's provided. Generally, there's two levels, kind of lower level and higher level. You can be picky about, you know, what higher level, but some of that is limited by what your institution provides you and what you have available. I think that for myself and for most of us, kind of daily and weekly updates and self-education along with the healthcare team in our environment are very helpful to understand where things are moving in your own town in terms of the epidemiology and the institutional updates. Lastly, everyone be safe. Thank you.
Thank you very much, Dr. Sato. And as we said, we'll leave the discussion till the end, but please allow me to ask one short question regarding how long is the echo that you would suggest for a patient with either is testing positive or maybe positive? For a first timer and a follow-up, how long would you recommend timing-wise?
You know, I don't think you can put a time on it, Rima, but let's think about it. For us senior sonographers, if we ourselves go in a COVID positive room on a ARDS kid, we could probably do that echo in 7 minutes. A couple of quick subcostal, apical, look at the arch, a coronary, a pulmonary vein, done. So it may not be beautiful, it may not be 180 clips, but arguably a seasoned sonographer or physician can get in and out pretty quickly. And so if you really want to talk about time, I think the answer is not the number, but who do you send to go in and out super quick?
You want senior people to deal with COVID positive patients, and you want them, you would agree that it would be like a standard or a focused ultrasound? Because usually when you do a normal child for first time, you would do a standard echo. There is like a protocol that we have to follow, and the follow-up is a different one. But in this case, you would just do the routine ones in a quick way?
It depends what the indication for the echo is, like always. Why are you being asked? You're proposing a COVID positive patient to be kind of playing the odds. Who is that? That's probably a respiratory distress patient in an ICU, most likely. So it may be less likely we're worried about ductal dependent congenital heart disease, and people want to know if there's a cardiomyopathic process, a large effusion, atrial level shunt that may be part to the stats you see at the bedside. Those are things that you can kind of boom, 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 knock out quickly with, seasoned sonographers or echo staff. So if it's a baby who had a prenatal diagnosis of heterotaxy, and I guess mom's positive or the baby's positive, which now you're starting to stack up the probability you're being low, then I think that's a little bit of a different situation. But you could even argue, based on what the stats are, the kind of hemodynamic stability of the baby, and what the question is for that study, even that first study can be a little limited if you have good pictures prenatal to some degree. So it's really hard to give a cookie cutter answer.
No, I can understand that there are two lines now. One is a congenital heart disease where you have to follow the protocol that you're known. And the other one is screening for somebody with COVID positive, no congenital heart disease. You want to do an echo on this baby. Then you have to do you do the routine for function and anatomy. I'm not sure if you do tissue Doppler and stuff like that. Mary, do you add to this? Mary?
Yeah. I would say pretty much what Gary said is that you need to use your indication. Obviously, if it's a murmur, you're not going to do it at all. If it's a COVID positive patient that, has signs of respiratory distress, you're going to do a function assessment, a look at the coronaries, a look at valve regurgitation, and you're not going to go after each, the aortic arch and is there co-arced and all that sort of thing. For the congenital heart disease patient, it's going to be a comprehensive study. Like if you have a baby who's blue, you need to sort of do a comprehensive study. The goal is to answer the question, but also not have to go back. So, if it's a rule out congenital heart disease, you want a complete study. If it's a bigger kid who was fine a week ago who has a fever, you want to limit that study to function and coronaries.
Would you do tissue or anything like that? Would you do tissue or strain?
Yeah, we would probably just take a quick tissue Doppler clip to follow TDI. It's whatever the function protocol is in your lab. I certainly wouldn't want to be spending a lot of time. You would need a 4-chamber view for an ejection fraction. You would do mitral inflow. You would do a tissue Doppler clip. Really, because what you're going to have to do over time is follow the function measurements.
Thank you very much. Now we move to the next speaker, Dr. Mary D'Onofrio from Washington, D.C. It's a pleasure to have her. She's the head of Fetal Society. It's a beautiful society. We encourage everybody to join this society. Mary, could you introduce yourself, please?
Absolutely, I can. Let me get my slides up here. Can everyone see? Yes? Okay. Yes. I'm Mary D'Onofrio. I'm professor of pediatrics at George Washington University, which is in Washington, D.C. I'm also director of the Fetal Heart Program and Critical Care Delivery Program at Children's National, which is in D.C. And I am president of the Fetal Heart Society. So what I'm going to be talking about today is the specific considerations for fetal echo and care of the fetal patient with congenital heart disease during this time of COVID-19. And as Gary mentioned, this is taken from the summary of the statement from the American Society of Echocardiography, which I did have the privilege of being part of that writing group. So this is the statement. It comes from the Council of Pediatric and Congenital Heart Disease that's part of the American Society of Echo. Pierce Barker from Duke was our writing chair. I represented the Fetal Heart Society as president, and Mark Lewin represented the Society of Pediatric Echocardiography as president of that society. Okay, so we'll start off with what does the Center for Disease Control say about pregnancy and COVID-19? Well, it's actually not known if the pregnant woman has a greater chance of getting sick from COVID-19 or if they're more likely to have a serious illness as a result of the infection. So what they say, in quotes, is that pregnant people seem to have the same risk as adults who are not pregnant and should follow the same recommendations, meaning social distancing, frequent hand washing, sort of avoiding thick contacts. However, they do add that pregnant people have changes in their body that may increase the risk of some infection, and that pregnant people have had a higher risk of severe illness when infected with viruses from the same family as COVID-19. And this includes H1N1, SARS, and MERS. So with this, they actually add that it is important, always important for pregnant people to protect themselves from illnesses. So what I'm going to try to do is answer the questions I think that Gary brought up as well, but as it pertains to fetal echocardiography. And we'll start with where to image, how to image, and then what's probably most important and changing what we do in the fetal world is who to image. And then I'm going to touch on delivery room considerations. So where to image? You've heard this. The goal is to minimize exposure to the pregnant woman, to her family, and to the staff. So first off, if at all possible, avoid the hospital. So if your imaging lab is in the hospital, try to think of alternative, like using a lower volume outreach clinic if it's available. Also, avoiding intermingling pregnant women and pediatric patients. This is for those of us who do our fetal imaging in the pediatric cardiology clinic. So it will be important to first off try to move them off site to an OB office or a satellite. But if that's not possible, to set up a system in which you can sequester pregnant women from the kids, both in the waiting room as well as in the imaging lab. This is from the statement paper, the guidelines for the visit, and this is what we follow at Children's National, is only one support person should be allowed to go to the visit. And this person should be screened in the same way the patient is screened and only be admitted if that screen is negative. Even with that one person allowed to accompany the pregnant woman, there should only be the pregnant woman in the scan room, so the support person needs to wait outside or in some other part of the hospital, and the scan room should be limited to just the pregnant woman and then the sonographer. And again, this is to minimize exposure of that sonographer to number of people. And then counseling is variable, and it should be limited to the pregnant woman and that one support person at most. Some centers are saying that that support person needs to call in and should not be present in the counseling room, and using telemedicine as an option in these instances. Certainly, if you're putting the pregnant woman and the support person in the same room, you should try for social distancing with counseling in a larger size room with everybody maintaining distance. Okay, I don't know why I'm not forwarding here. Give me a second. Okay. Other things to consider is the use of telemedicine, and there's lots of novel ways that we've introduced telemedicine at our facility. First off, in the US, the level 2 ultrasound that's done at mid-gestation, which is the anatomy scan, does include a cardiac screen to it that includes, according to the ISWA guidelines, 4-chamber outflow tracts and 3-vessel trachea view. So if you can review that scan in some way, either by telemedicine visualization of those images or by discussion with the obstetrician who's doing that scan and determine that that scan is normal, you may not even need to do the fetal echocardiogram. Also, you can use telemedicine to review studies that are done in these lower volume, lower risk sites, whether it be the MFM or obstetrical office or in your own perhaps outreach clinic, that the pregnant lady goes, gets the scan done, and then you read it remotely and counsel them remotely. Counseling, telemedicine is very good for counseling, and this is with images or without images. So if you're looking at images remotely, you can talk to the families while they're at home. And what we use this for is the in-between imaging. So you'll see that when you're doing fetal echocardiography and you identify congenital heart disease, you have that first scan, and then what we're doing is canceling all the in-between scans and then doing only a scan right at the end for delivery planning. But we are sort of reaching out to families monthly and doing telemedicine visits without imaging, really to continue to answer their questions as the pregnancy progresses. Second opinions, if you have the ability to review images, are certainly good then to talk to families via telemedicine. And then what's interesting that we've started to explore, and it's been very useful, is arrhythmia management and then surveillance of autoimmune, so that's SSA positive mediated follow-up for looking for progressive AV block. So we give the moms a home monitor to assess heart rate twice a day, and then we follow through with telemedicine visits to go over what heart rates they get. Okay, let's move on to how to image. You've heard a little bit about this from Gary. I think the imaging protocols in general, studies performed on confirmed or suspected COVID-19 mothers should be, number one, comprehensive enough to avoid need to return for additional images. So however you can get that best scan the first time is important. If you need to do follow-up scans, they should be tailored to the indication and planned in advance. And the goal is to minimize scanning time to obtain the highest quality images and the complete data set. And this is when you sort of need to think about who is your most experienced imager. And it certainly may affect the training of fellows and maybe some sonographers. So you need to think of novel ways to giving them their experience as we progress through COVID-19. Prolonged scanning should always be avoided. And the group who put together this statement felt that transvaginal fetal echocardiographic studies, which are done in the first trimester, should not be performed at all during this time. So how do we image? PPE for sonographers is essential. At our institution, that includes a mask, not N95, gloves, and eye protection. So we wear goggles. So remember, these are for COVID negative moms who have screened negative. So obviously everything changes for COVID positive moms, and we probably wouldn't even do the study in a COVID positive mom. The protocol for fetal echo, this is different than what we just talked about for pediatrics. For the first exam, it must be a complete study for a new consultation, and this is to minimize the need for repeat evaluation. The goal is to do one study and do it right. So with this, you need well-defined study protocols. There are study protocols in the AIUM document, guidelines for fetal echo, in the AHA document for fetal cardiology. And just to be sure that your studies are complete, we put imaging checklists in the scan room. And then the study is reviewed by the reading physician prior to the pregnant woman leaving that exam room. Follow-up scans, if they're deemed necessary, and this is very rare that they're deemed necessary to do follow-up scans beyond that third trimester scan, which we do think is essential, and I'll talk about that in a minute. But follow-up scans then should be focused based on this predetermined checklist. We use huddles between sonographer and the fetal cardiologist before that exam is performed so that all the data is acquired. Okay, equipment, the same applies for fetal imaging as it applies for the postnatal imaging. Ultrasound machines definitely represent a potential source of transmission. So if you're in an area of high-risk patients, you should designate specific machines for those COVID positive, or what we call the PUIs, or people under investigation. Covering high-touch surfaces to decrease bioburden and simplify cleaning have been recommended. There are multiple different guidelines put in place, including the AIUM and then vendor-specific guidelines for cleaning machines, and so they should be followed. You've already heard this too. The reading areas create the potential for community transmission. So you should adjust. What we started out by doing is to adjust staffing to minimize exposure and maintain our operational readiness. You should consider creating sonographer and staffing teams that alternate, and this is to keep at least a group of people safe, such that if someone is exposed, you're not suddenly without a sonographer or a faculty member. Also, we've had to adjust faculty coverage to match the changes in clinical volumes, which are down. But be aware, and at our place to assign, what we've done is to assign non-clinical but lab essential projects to maintain our staff during this time. Remote reading and report generation is important. And frequent disinfection of the reading room, any high-touch surfaces, keyboards, the mouse surface areas, chairs, doorknobs, light switches. It's all important to disinfect them at least daily, but likely more frequently than that. And discourage congregating in the reading rooms. So we do a lot of phone conferencing and Zoom conferencing. So I think this is the most important and probably the biggest change when we think about fetal cardiology and fetal echo imaging, is who to image and when to image them. Again, the general rule is we should only be performing studies that are expected to provide clinical benefit in the short term, considered this risk due to potential disease transmission during COVID-19. So first you need to define AUC, which is appropriate use criteria, and then determine if the study is indicated, and then define elective cases, and then consider delaying and rescheduling them, and then to truly determine the urgent indications, and then figure out how to safely take care of those patients. This involves triage and certainly consultation with the referring physicians. Okay, this is directly from the statement paper. Fetal echo visits should be triaged such that only those with moderate or high fetal risk are scheduled. So now we're talking about the fetus. So who has the moderate or high risk? The risk is determined by the likelihood of congenital heart disease compared to the general population risk, which is believed to be about 1%. So referral indications above 1% kind of are risk stratified to determine the likelihood of congenital heart disease. But we also now need to take into account the adequacy of the OB scan, that anatomy scan with the cardiac views that I already mentioned. And then the gestational age becomes important. The high-risk gestational age window that we talk about is that less than 24 weeks is considered high risk because there is perhaps pregnancy decision-making, there's the need possibly for additional testing like an amniocentesis or a fetal MRI. And then there's this kind of quiet period between 24 and 34 weeks where really not much is going to happen and there's not much you can do. But then after you get past 34 weeks, you're again in a high-risk window because of the need for delivery planning if there is fetal congenital heart disease. Any fetus that there is a potential for treatment is considered high risk, like the tachyarrhythmias, the bradycardias, and interventions for lesions amenable to fetal cardiac catheter intervention like aortic stenosis or hypoplastic left heart with a restrictive septum, given the risk benefit is still a little bit uncertain, we've left this to the discretion of the fetal care centers. So the table that's part of this document, I think it sums up things nicely, and I actually printed it out and pasted it in our lab. So I'm just going to go over it quickly. Low risk patients. These are patients that have a low risk referral indication and a normal detailed second trimester anatomy scan, including some documentation of adequate cardiac screening views. So whether you trust the referring obstetrician that they do a good cardiac screen, or do you need to review the images to determine that, will depend on your local practice. The low-risk referral indications include IVF, gestational diabetes, in general family history, medication exposure, single umbilical artery, and dichorionic twins without additional concerns. So for these patients, we're actually suggesting that you cancel it or don't schedule it at all. The moderate risk patients are those that have moderate or high fetal risk that's within that gestational age window where really not much can be done. So greater than 24 weeks and less than 34 weeks. So these referral indications are second opinion for congenital heart disease that's already been identified. If the fetal anatomy scan cannot confirm a normal cardiac structure, and then these high-risk referral indications such as pregestational diabetes with elevated hemoglobin A1C, increased nuchal greater than 3.5, or very rare specific congenital heart defects that have an increased recurrence and first-degree relatives like left-sided obstructive lesions, heterotaxy, and actually maternal AVSDs. So these patients should be scheduled, but paying attention to schedule them in the third trimester, so after 28 weeks at least. We create a virtual waiting list so we don't lose these patients, and either when the risk of COVID-19 goes down or we're in the third trimester, then we bring them in. And then lastly, the high-risk group, fetal echo should be done promptly, though again, considering alternatives, to minimize the risk. And this is the gestational age range of less than 24 weeks and greater than 34 weeks. They should be scheduled at next available. And here is the list, not surprising: suspected congenital heart disease with known risk for progression, that final visit at 34 weeks for delivery planning, if there's genetic abnormalities, arrhythmias. The SSA ladies, we schedule them at their first visit and then teach them how to use that home heart rate monitor. You can't confirm normal. Monochorionic twins are considered high risk. And then again, these high risk indications that I already mentioned, but at the gestational age less than 24 weeks. And then we added this, honestly, if the mom has severe anxiety and you can't calm them down with even a telemedicine consult, it's really worth bringing them in. Okay, so putting that together, low risk, you need to determine the adequacy of the cardiac views on the anatomy scan. If the structures are normal, you cancel it or don't schedule it at all. If you can't confirm it's normal, it depends on the gestational age as to whether it moves to high risk or moderate risk. In that moderate risk group, so remember what all we're doing is trying to time the visit to be in the third trimester, hopefully when the COVID risk goes down. And in the high risk groups, you have to schedule the next available, use telemedicine, really any chance you can get. And a word on delivery, vertical transmission from mother to fetus. The CDC says it's unlikely, though honestly the data is inconclusive. There are 3 articles, all of them from the Chinese experience. There's one that came out in JAMA Pediatrics that 33 positive moms There were 3 babies that were positive within like 3 hours after delivery with a throat swab. So that raises the question of vertical transmission, and I think makes us all a bit nervous. So what we suggest in the statement is the advantage of universal testing of pregnant women on labor and delivery, determine the risk. And then for those moms who are found to be COVID-19 positive, within 14 days of delivery, the newborn should be considered a PUI, so a person under investigation, and treated as positive until the baby can be confirmed to be negative. I think this is important. The New York experience found with universal testing that about 20% of their moms were COVID positive upon arrival to labor and delivery. So that really is a scary number. I want to share with you this. This is our protocol that we put in place. Keep in mind that we're a children's hospital and that we deliver kind of at the adult hospital that's across the street from us. We have cohorted the neonates that we consider under investigation in our neonatal intensive care unit in negative pressure rooms, and have decided that our cardiac intensive care unit is a COVID negative intensive care unit. So with all that in mind, we do universal testing on labor and delivery. They come in the night before, they get their test. If they're negative, then we consider the baby negative, and then the baby can go to the cardiac unit. So these are babies with congenital heart disease that need surgery. If the mom is positive, or the test can't be done because they come in spontaneous labor, or if they're negative but the mom fails the screen, like they have a fever or a cough, in contact with somebody who's COVID positive, then we consider them what we call the PUI. And then what we do depends on the disease. Level 2 or the ductal dependent lesions, they will go to the NICU until we can prove that the baby is negative, and then they move to the cardiac unit. Otherwise, they stay in the neonatal unit, and we consult in that unit. The 3s and 4s are those babies that need an intervention right after birth and are not stabilized with prostaglandin. Still, they need to go to the negative pressure room in the NICU until we can confirm they're negative, and then they move to the cardiac unit. If they're positive, we have to consider how to manage them. And the specific examples are transposition, when you need a balloon. That procedure is being performed in the NICU with us going up there. And then we manage the baby until they're COVID negative, can be confirmed COVID negative. We haven't had one of these yet, but hypoplastic left heart with an intact septum would go straight to the cath lab with all PPE in place, but then would go back to the NICU for that care, with actually our cardiac intensivist managing the baby up in the NICU until we can transfer them down to the cardiac unit. So all this needs to be individualized depending on what your local resources are to determine where you want these either COVID positive babies or these babies who are considered under investigation to be. So in summary, patient triage to determine the need for the visit is most important. Patient risk is determined by indication, the clinical cardiac diagnosis, the gestational age, and the potential for treatment of the fetus. Consider telemedicine to minimize visits. PPE is super important, and maternal COVID-19 status is important for delivery planning. These are the same resources that Gary showed, added a few of them at the bottom. This is the end to the fetal part. I was asked to talk a little bit about some other things. So here's a couple of extra slides. What's interesting is just, what part of the curve you're on depends on your region. And in our country, in the US, it's all over the place. Where New York was our hotspot and Seattle was our hotspot, when this all started. They've actually now are now on their downward curve, which is wonderful to see. But in Washington, D.C. and the surrounding regions of Maryland and Virginia, we're actually on the upswing. So in our city, we are now seeing more and more cases every day. So we are currently on an upswing of admissions with COVID-19. The other thing to mention is this new thing, which is atypical Kawasaki's disease. We are seeing this. We are a pediatric hospital, and we are now seeing this. We have 3 kids in our pediatric ICU COVID ward that have been diagnosed with this. For these patients, particularly if they're on that COVID unit, we are using full gear. This is me. I have the N95. I have goggles and then a face shield, a gown, double gloved, with a process to enter the room and exit the room, and then doing, obviously, imaging. We say that the COVID positive patients must be imaged by the attending physician, not the fellow, not the sonographer, but the attending physician, and that's to kind of minimize the time and maximize what exactly information we need. Here's an example of a 6-year-old healthy kid, got a fever, showed up in our emergency room in cardiogenic shock, was hypotensive, got fluid resuscitated, got inotropes, was intubated because of respiratory distress. And this is his first echocardiogram showing dilated coronary arteries, diffusely dilated. And you can see maybe even a small aneurysm of the left main. And then here we had mitral regurgitation and a decreased ejection fraction. Here are the numbers. The coronary Z-scores were elevated of both the left and right, and the ejection fraction down here at 42%. This patient is treated as a Kawasaki's, got IVIG infusion, and aspirin, as well as supportive ICU care. And so far, the 2 patients that we've had with this have recovered. And as far as I know, there haven't been any deaths reported for this Kawasaki's type disease. So with that, I will end.
Thank you very much, Dr. D'Onofrio. It's very, very, very interesting and very important talk. We'll leave the questions at the end, but just before, so that we understand what you said, that the low risk and the high risk in the fetals that you showed is not the same as when we do the routine scan, when we identify that, because most of the congenital heart disease is in the low risk population. But when you mean, what you mean today by low risk and high risk is in relation to the COVID. Correct? Did I get this right?
That's exactly right. That is exactly right. So if you have a low risk referral indication, like IVF or something that's just at the 1%, and you can confirm that the anatomy scan is normal with the cardiac views, that counts as a low risk patient in time of COVID. And even the high risk indications, if you're in that gestation, if you can confirm that the cardiac screen is normal, that's a low risk patient. So, you know, if you have a diabetic and you can assure yourself by reviewing the anatomy scan that that heart is normal, then, you know, you don't need to bring them in for a fetal echo. So it's really the confidence level in your referring physicians. And then you can sort of add to it the risk of congenital heart disease. Like if you have a diabetic whose hemoglobin A1C is 12, and the cardiac screen is normal, but you're 32 weeks, you might want to do a fetal echo in that instance. So it's really balancing the risk benefit within that patient, and then taking into account the safety factor.
Thank you very much. Now we go to our panelists, Dr. Khalid Al-Aqqas from Mecca and Dr. Khalid Al-Zahri from Eastern Region. Dr. Khalid, would you like to give us, I mean, for people who don't live in Saudi, Mecca is the holy region in Saudi Arabia, and it's a heavily populated area. And in Saudi, according to the latest statistics from the Ministry of Health office, is this the highest? Mecca is one of the highest regions of having new cases. And Dr. Attas is head of the Echo Lab in the Maternity and Children's Hospital, which is the biggest hospital in the area. Could you please update us just very quickly on what you have and what you see?
Thank you, Dr. Rima, for the invitation. Still, we have an increasing number of infected pediatric patients with COVID-19. And but the number of patients getting admitted to our maternity and children hospital, which is the largest children hospital in Mecca area, still very little number. It's around 30 for the last 1 month to 6 weeks. 30 patients. Out of those, only 10 to 11 got admitted. And out of those, only 1 with congenital heart disease who presented with 4 months with acute fever and acute severe gastroenteritis with some acidosis that require 1-day admission to the ICU. This is regarding the small pediatric population. The elder patients, more than 14 up to 18, they got admitted to the adult wards, not in our hospital, in another hospitals. And but so far, most of them they are getting treated very well and discharged home after, according to the criteria, after 2 negative specimens. We have to the ICU 1 suspected child born to proved COVID-19 mother, pregnant mother. The mother got admitted to the ICU, but the baby was negative, and he did very well. Another pregnant lady with COVID-19, she came to the emergency OB-GYN room with a stillbirth for her child. The child was born dead. So to the ICU, we don't have so far any single approved COVID-19 newborn. This is about our hospital. About the general status in Mecca area, we still have more than 600 patients for the last weeks. But most of them, they are doing fine and getting discharged according to the results of the screening. This is a short summary about the status in our city.
Thank you very much, Dr. Khalid. Now we go to Dr. Al-Tahari from the Eastern region. Welcome, and we're very much interested to hear from you, Dr. Al-Tahari.
Thank you very much, Dr. Rima. So basically, the Eastern province is the largest, actually, province in the kingdom. And it's divided into 3 regions. The Al-Hassa and Hafr al-Batin, and our Eastern province, the main area where the main cities, Dammam, Dhahran, Khobar, and Jubail lies.
Khalid,
for
I can see the screen. Khalid, we cannot see your, are you sharing the screen?
Yes, I'm sharing the screen.
We cannot see it.
Okay. We cannot see the screen, please.
Okay. Well,
okay,
now
you
see it now?
Can see it. Thank you. Yes, we do.
Yes.
Thank you. Yes, thank you.
Yeah. Okay. Thank you. So the Al-Hassa and Hafr al-Batin, I don't have exact numbers actually. Al-Hassa, I was told the same thing. There is more than 100 cases. There was only 1 case admitted to the ICU, but the reason for admitting a COVID-19 positive to the ICU was because she has a DKA. Okay, otherwise none admitted to the ICU. In our region, the total number of COVID COVID-19 positive is 6,557, and the children is only 147 cases. And 91% they actually were in contact with COVID-19 positive patients, and there was 7% returning from travel. So they came actually from in areas where the COVID-19 was epidemic there. And as you can see, 93% were asymptomatic, 7% had mild symptoms, and 4% were admitted, but no ICU admissions. 96% quarantined. Recovery is 64%, and currently the active cases are 32%. That's it. Thank you.
Thank you very much, Dr. Khalid. What we going back to the panel now. We have some questions for all four speakers and panelists, please. When we go to Dr. Satu first, Gary, regarding the testing, what do you do for testing? The question, what test do you use?
It's nasal swab PCR, and it has to be within 48 hours of every congenital heart surgery case, every cath case.
Okay, so you're doing the PCR, and we know that there are false positives and false negatives as well. So do you go for symptoms plus lab tests?
I mean, we're doing universal screening for those patients. If there's a negative test and a positive symptom patient, yes. I don't know the answer. I suspect that the care team at the time is probably doing repeat testing or something different if a different option at all exists. The pediatric infectious disease team at UCLA Health is everywhere, and so they're consulting with all the various services, and they would know better than I.
And also, we were talking about your rate of cardiac surgery, that you did not stop. At first, you put things on hold, and then you went back to full power. Is this correct with your cases, because they couldn't wait?
Yeah, over the last month or so, we put a halt to cases that didn't need to be done at the time. But as I mentioned prior, we all have cases that can't wait, whether it be a newborn with a ductal-dependent lesion that either needs a ductal stent or a shunt, or detransposition that needs an arterial switch within a week of life. There's scenarios that can't really and shouldn't be put off. We're finding that with all the proper levels of care and caution, that everything's going smoothly. At UCLA Health, we're very slowly starting to reintegrate relatively elective cases back onto the service.
And what about the question goes to your clinics? Are you doing virtual clinics, telemedicine? How are you dealing with patients during this pandemic? The routine, the cardiology patients, outpatients.
Yeah, it's very interesting. Here in the Children's Heart Center at UCLA, I don't think any of my colleagues were doing telehealth or televisits before COVID. Now everybody's an expert. The encounters were basically morphed into almost exclusively telehealth visits for a large number of my colleagues. I tend to follow the babies with congenital heart disease largely in my practice. So I have had my patients, when necessary, still coming through lower volumes, but I'm still seeing those patients. I can't really supplant the echo and the pulse oxsat and wound check and things like that for too long. So it depends who you are within our group, but a large number have almost exclusively been doing telehealth. We are now, again, just starting to reintegrate towards in-person visits mixed with continued telehealth.
Thank you. Any of our team would like to ask Dr. Satu any question? Dr. Khalid, Dr. Dahri, any questions to Dr. Satu?
No, thank you.
Now the question goes to Mary for the fetal life. Now, thank you very much for enlightening us with this information. Now the question goes for basically when the message is that stay home, stay safe for pregnant ladies as much as you can. Is this correct?
Yeah, absolutely. I mean, I think that's true for all of us still, to stay home, stay safe, social distancing. I think it's that much more important for the pregnant ladies, given this uncertainty. They are immunocompromised and have suffered from other viruses that are similar. I think additionally, what I struggle with the pregnant ladies is that certainly the ones with congenital heart disease, as we head towards the third trimester, it's that much more important. Because it will affect the delivery. One, we don't know about vertical transmission 100%. And then secondarily, it will just affect the whole delivery process. That if a woman walks in to labor and delivery and is COVID positive, first off, her significant other, husband, will not be allowed to be in the delivery room with her. If they're COVID negative, then one support person is allowed in. So that becomes really important. And then as I highlighted, if the mom is positive, then that affects the way we take care of the baby. And it makes it that much more challenging to get things done, whether it's a balloon septostomy for TGA or whatever else needs to happen. We have yet to have a COVID positive baby. But certainly what we know that in general, the congenital heart disease babies are not affected any more than any other child. And in general, children do not have severe disease, with the exception of this really small number with this Kawasaki-like disease. But there is data that's saying that if you are COVID positive and you need cardiopulmonary bypass, the risk is higher. And I know the STS is starting to gather that data to say, what are the surgical outcomes in COVID positive patients who undergo bypass. So not as much of a neonatal issue like the newborn, but certainly for the older kids, it becomes important. And that's one of the additional reasons that we're doing universal testing for anybody who needs heart surgery. If they're gonna, if you're coming in with tetralogy and you need a conduit change because your RV pressure is elevated and you're COVID positive, the question is really, can it wait until you're negative to minimize the risk of bypass? So there's lots of questions still out there to risk stratify these patients based on their status.
I'm not very sure that it's quite correct when you said that children are not more prone to COVID. Yes, everybody.
No, more prone to severe disease. They're less prone to get very sick from COVID. They're, kids get it.
Yeah, agree.
They get it at a very high rate. They aren't sick, and that's why they're probably our biggest vector. But they're less likely to get really sick. And that's true whether you have congenital heart disease or not.
This is the issue that they can spread the disease without being noticed, right?
Absolutely, absolutely.
For congenital heart disease, there's a paper also in the Chinese literature. They looked at the immune-compromised patients, and they looked at the catch-22 and so on. But they said that people who are like catch-22, G. George, and so on, are with congenital heart disease are more prone to get So they are on the side of immunocompromised to children to get the disease. Do you agree to that?
I don't have enough data to say, but certainly I'm worried about it. I mean, if you have heterotaxy or G. George, I think they're at risk. That's what the guidelines sort of say, that anyone who is immunocompromised in any way, that includes the grown-ups, or an increased risk of getting sick from this disease. So I do think our group of congenital heart disease patients who also have this risk, we have to worry about them for sure.
So the message is to our staff, to the medical people here. Take care of COVID patients, but protect yourself as much as you can. don't stay away from them. They need help, but protect yourself. Is this correct? I mean, everybody's trying to protect the healthcare professionals worldwide, because it seems that we get a bigger dose of the disease.
Yeah, I think so. Of course, we have to protect ourselves because we're not going to be able to do our job if we get sick at a minimum. And certainly the fear of bringing it home to our own families is there. Yeah, you know, and I think what's interesting to see is we've, you know, before our peak, and we're now, as I showed, starting to see more and more. We've spent the last month trying to figure out how to make sure we're not in a room together. We have 4 surgeons, they're never together. And in our echo lab, we usually have like 4 readers, and currently we only have 1, maybe 2 readers that are at least 6 feet apart, and then the others are remote. You know, so everything that we do protect the faculty, and then the staff as well. We've had a lot of difficulty with, you know, if we have, you know, our sonographers, half of them won't have anything to do. And so we're finding other projects for them to do so that some of them can be remote, and then they switch off, because the last thing you want, you know, if one person gets it and they happen to be in a room with 4 other people, all those 4 other people have to be quarantined for 2 weeks. So your staff can go down to nothing pretty quickly. And we have had that happen with our nurses. There was a period of time where we lost, they were really just exposed. None of them got sick, but it was 14 days that we didn't have the nurses that we needed to keep our unit at full staff. So these are the kind of things that we have to think about, certainly, and protection is key.
Another message is that I mean, we know that you could test negative, but it is false negative, and if you have if the patient has symptoms, you have to be more cautious. I mean, we don't take it lightly. This is another message, I think, from both of you, is that be cautious. The test is not everything. We go by symptoms plus test. Is this correct?
Yeah, I think so. And I think, you know, interestingly, I was on another webinar, and the Seattle people, they trust their test like as a one-time test. At Children's, we have a very rapid test, but there's a 30% false negative. So we do 2 tests 24 hours apart to decide somebody is truly negative. You know, so there is variability in the testing. If you have someone who screens positive, you can't totally rely on the testing. You know, we had one patient who had all the symptoms and was tested 3 times, and then the 3rd time they turned positive. So whether we're, you know, not getting the swab wasn't good enough, or it hadn't sort of to the amount that's needed, you know, it's hard to know. But you can't trust the test 100%. You have to use both of them. I think if somebody had a fever and a dry cough, you know, we would consider them a PUI and take the precautions needed. We definitely are seeing the patients. We're not turning people away. And I think the challenge is, it's, you know, really easy to identify the truly elective patient, like an AST that the kid is totally fine. And then it's really easy when you have transposition or hypoplastic left heart. You got to do something. But the ones that I find most challenging are all the in the middle ones, you know, the tetralogy that has systemic RV pressure, whose RV function is good. They can wait a month or 2, but they can't wait 6 months. So, you know, in that instance, as I was saying earlier, is that your initial thing of what we did was to say only emergency cases until we're ready. And ready means PPE, the ability to kind of re-sterilize PPE, to have protocols in place with people trained to do it correctly. And then testing became important, to be able to rapidly test and make decisions. And then once that happened, you can then start to do cases that aren't an emergency, but you know, they're not going to go away. And I think the realization that this COVID-19 is not going to be gone by the end of the summer then makes us think that it's going to be around for a year or two. So we have to have a process to take care of those patients that need an operation, even if it's not an emergency. And so as we slowly ramp up, even though we are increasing in our numbers, we feel like we've got a handle on it. They're tested. We know if they're positive or negative. Everybody's got the appropriate PPE. So now we can safely do that patient who needs an operation. You know, a VSD with compensated heart failure, tetralogy with, you know, who needs a conduit change, those kind of things.
But Mary,
Dr. Arima, I have a question if you...
Sure. Please do, Dr. Khalid.
Yeah, I have a question to Dr. Gary. He mentioned that any patient is going for cath intervention need to be screened within 48 hours before going to the cath lab. Do they do the same for cardiac surgical patients as well? This is question number one. Second question, after resuming and reoperating the scheduled patients for cardiac surgery in pediatrics, do they notice any increments in the number of staff infections, increasing infection within the staff, or with all these precautions and the pre-testing, the staff are safe? Some of the surgeons in some instances deferred a lot of patients. Some of them are necessary from the possibility of getting infected with this COVID-19. Thank you.
So for question number one, yes, we as well are performing testing on every cardiac surgery patient that goes to the operating room. So cath lab and the operating room. In terms of question two, I'm not aware that there's any increased symptoms that have been noted. If I understood your question correctly, after the fact, in terms of in the ICU or elsewhere, now that there is an increase in interventional and surgical patients. I do know that about 4 to 6 weeks ago, there were a couple of nurses and a couple of pediatric cardiac surgical nurse practitioners that had maybe a mild cold, had been tested, and were quarantined for a couple of weeks before they came back. But we've been very fortunate that no patients have, and really a mass effect to the staff didn't happen. But there were a couple of nurse clinicians that were tested as positive. That was before we actually reopened, if you will, the volumes.
Yeah, thank you very much. I'm glad to hear that there is no increase in the number of staph infections. Thank you very much.
Yeah.
But Gary, what do you do if there is a COVID positive patient that has to go to open heart and go on bypass? I think this is the scare here. What are you going to do? The bypass machine will be infected?
Well, it's a good question, Rima. I'm not sure I'm the best person to answer that. I think, like a lot of what we've talked about today, we're hypothesizing A, B plus C and D. The good news is the probability of those patients are very, very low. So I think that if you get in that situation, you, number one, reassess, do I really need to go to the operating room? And the answer is probably yes, if you needed to the first time, COVID or not. Although, think about it. We've got patients who need to go to the operating room, have mild URI symptomatology, and they test for RSV. They test for something else, flu, paraflu, what have you. I think each institution and each care provider, and anesthesia especially, they're usually one of the last bastions of screening. I think they make the decision case by case if the case is going to go. We might have on the cardiac team a willingness to proceed, and anesthesia may say, sorry, we're going to make you kit the kid on PGE and park it for a few weeks till we're clean and negative, better x-ray, blah, blah, blah. So I don't know the answer if you have a definite needs open heart surgery procedure and COVID positive combination. If I was on service at the time and that was my patient, I know there's others I would run to, including Glenn Van Arsdale, our surgeon, to help make the decision. It would be a group decision.
And the perfusionist, of course. Do you drape the probes when you do it and do routine transthoracic echo? Do you drape the probe in the hospital nowadays?
Well, because we know the patient's COVID negative, we have not. That's not to say it's not very reasonable to continue to do so. But we will use an N95 and a shield and a gown and mask, and there's a drape on the knobology part of the machine, but we haven't routinely been draping the probe itself. Obviously, the epicardial probe is always draped along with the cord. We do a lot of epicardial, all epicardial at a minimum for our cardiac surgery cases, but no for those, primarily because we know the COVID status of the patient if you believe it's a true negative test.
Rima, we do cover the probes for the COVID positive patients. We use the same sleeves that we use for the epicardial echoes. Cover the probes, cover the machine. And then you need to totally disinfect the machine before you leave the negative pressure room. And then after you leave the negative pressure room, it just is twice total wipe down of the machines. So yeah, I mean, I think if you have a COVID positive patient, you need to take every precaution.
Thank you very much, everybody. Also, thank you for taking attention about the coronary and Kawasaki-like syndrome, which is now everybody's talking about the atypical presentations of the COVID-19 children with what looks like well, coronary or myocarditis or pancreatitis. And as Dr. D'Onofrio said, that they treat them nowadays till evidence shows like Kawasaki. I think we understood that from you, Mary, right? The cases that
yeah, correct. Yep, that's the plan so far.
Okay. I think we've come to the end of our webinar, and I'd like to thank our eminent guest speakers and our eminent panelists and our participants. And I'd love to thank our team from Saudi Heart and the IT technicians and the nurses and the secretaries of the society. And I think we can all leave now. And for local people, good night. And for people in the US, have a nice day.
Thank you, Dr. Bader.
Thank
Be
you.
well, everyone.
Thank you. Bye.
Bye, everybody.